This first part of hemononc pathology really just looks at pathologic RBC forms and then appropriately follows it up with the beginning of the various types of anemias and their classification. Anemia is very high yield on step one and obviously very popular in real life too. You get patients that come in with different kinds of presentations, but they're all the same thing. They're all anemic patients, and you really have to figure out what's causing the anemia. The anemias can all also be very different from each other because iron deficiency anemia causes a microcytic anemia, whereas folate or B12 deficiency causes a macrocytic anemia. So you really have to be able to classify the anemias based off of stuff like that. Before we go into that though, let's just look at the quick review of pathologic red blood cell forms. So the first thing you see are acanthocytes, which really are finger-like projections. So they're very spiny. These are long projections. You can see it's like quite a long spine is coming out. It doesn't look like something's pushing from inside, but more so that you actually grew a spine. See, if you have a circle and if you point from inside, if you somehow could manage to do that, then you would also cause a bump, right? You wouldn't just point, like it wouldn't just be a straight finger coming out, but you would actually cause a bump of the surrounding area too. This is just a straight finger coming out, so that's a spiny formation, right? So acanthocytes or spur cells, this occurs in liver disease, and that'll be the number one thing you'll really see it in. Liver disease is going to have acanthocytes. The other place we already saw acanthocytes in was in biochemistry when we were at the end of metabolism. And right at the end of metabolism, we saw something called dyslipidemias, one of them being A-beta lipoproteinemia, right? So this thing right here, A-beta lipoproteinemia, autosomal recessive, right? The mutation in gene that codes for a microsomal transfer protein, MTP, it basically leads to an absence of LDL, VLDL, and chylomicrons. You have an absence of all of that. So now this is all due to a deficiency of ApoB48 and B100, which you really need. Affected infants present with severe fat malabsorption, steatorrhea, failure to thrive because you're losing everything, right? It's all just coming out in your feces and you're going to lose all your fat-soluble vitamins. Later manifestations include retinitis, pigmentosa because of vitamin A deficiency, spinocerebellar degeneration due to vitamin E deficiency, ataxia because of E deficiency, and acanthocytosis. And if you do a biopsy, you would see lipid-laden enterocytes. But the real thing to really watch out for is that the blood smear would show you acanthocytes, right? Because this is a type of a liver issue, right? And this is a bigger peripheral blood smear showing you a bunch of acanthocytes. So you see how these are kind of, these right here, these are kind of spiny, all right? So that's you seeing acanthocytes, which is a pretty common thing to see in A-beta lipoproteinemia. Also from nutrition, if you forgot, vitamin E deficiency and vitamin B12 deficiency can have a very similar presentation because they both cause certain kinds of degeneration of your nervous system, but there's a difference between the subacute combined degeneration and the spinocerebellar degeneration of vitamin E, so make sure you know that difference too. Anyway, that was your acanthocyte. The acanthocytes, unfortunately, look very similar to echinocytes, but echinocytes actually look like fingers pushing out from inside, so there's actually a bump on the surrounding, right? And echinocytes are related to renal disease, right? So spur cells for liver, Burr cells for end-stage renal disease. Burr has two R's because you have two kidneys, two renal portions, right? It's also seen in liver disease as well, though, and pyruvate kinase deficiency, which was another thing from biochemistry. So if you forgot what pyruvate kinase deficiency was, and if you forgot what the get-around technique of treating patients with pyruvate kinase deficiency was, you should definitely go back and take a look at that. Now, whether or not you have one or the other, if it's a question about liver disease, you could have both. So don't really worry about it too much. They tell you to differentiate from acanthocytes because this thing, echinocytes, the acanthocyte, its projection are more uniform and smaller. Right, so this is all very uniform and small, whereas here you have bigger projections. Kind of hard to see that, especially if you have many red blood cells and they all kind of have acanthocytes and echinocytes happening, but you should be able to make the differentiation between the two the best you can. Dacrocytes are very obvious. This one right here is a very clear dacrocyte at the bottom right. It's basically a teardrop cell, and it's happening because your bone marrow is crying, right? The red blood cell sheds a tear because it's mechanically squeezed out of its home in the bone marrow. Bone marrow infiltration is the main reason you get this. So this is usually going to occur in patients with myelofibrosis. And we're going to see that later on. Myelofibrosis and thalassemias, we're going to see as soon as we get into that area after the anemias. So here I wrote, seen in beta-thalassemia major or myelofibrosis anemia due to myelofibrosis, which is a rare bone marrow cancer in which an abnormal clone of hematopoietic stem cells in the bone marrow and other sites results in fibrosis of marrow. Could be due to mutation in JAK2 Janus kinases, which is a really big deal in hematology. Non-receptor tyrosine kinase is essential for activation of signaling that is mediated by cytokine receptors lacking any catalytic activity. So Janus kinase, we're going to see as we move on, is a really big deal with a lot of polycythemia and anemias, and you need to make sure you can pick that acid choice correctly when necessary. Dacrocytes we've already seen. Dacrocyte is just a technical name for bite cells, which we saw mainly with G6PD deficiency. Right, so you basically take a bite out of a portion of the red blood cell that has a Heinz body. There was a Heinz body here, and it got bitten out. So that's what they're telling you, due to removal of Heinz bodies by macrophages in the spleen. Right? And the only way to stop this from happening is to do a splenectomy, get rid of the spleen. Elliptocytes, I've never seen in a question, but they're pretty elliptical like this, very linear, flat, looks like a club. Hereditary elliptocytosis is a disease where you actually go ahead and actively do that, usually asymptomatic, caused by mutations in genes encoding red blood cell membrane proteins like spectrin and ankyrin and a bunch of others that you really need to know well. Macroovalocytes are like this, really big red blood cells, pretty much the size of 2, and this is what you're going to see in myeloblastic anemia, right? And this is basically going to be a symptom of either B9 or B12 deficiency, both of which also present with hypersegmented neutrophils that have more than 9 segments to it. This is an image from AMBOSS, which is kind of showing you directly specific cells. So the schistocytes you can catch immediately, right? Schistocytes are your helmet cells, which occur due to thrombotic microangiopathies like DIC, TTP, anything like that. And over here, they only mention G6PD, right? But you can get that in many other scenarios too. Or mechanical damage because of artificial heart valves. Here, the E labels show normal erythrocytes, right? So you can see this one is normal, this one is normal, right? While the circled cells are helmet cells, and you can see that, right? They even outline the helmet aspect of it. You can also see some red blood cells that look like echinocytes, right? Like there's this one right here. Okay, what else is there? This one has weird projections. That has weird projections. This has weird projections. So when you get stuff like this, you know, the main thing that you always want to catch in something like this is the presence of your helmet cells, and helmet cells are a really big deal. Once you catch that, once you see the bite cells, you immediately think of G6PD and try to figure out if it is any of that. Otherwise, you think of other reasons the patient could have Heinz bodies, and we're going to get to that soon enough. The last few, there's been some new changes here in 2019. So in your ringed sideroblast, which is like this is seen in sideroblastic anemia. You basically have excess iron in the mitochondria. So this is seen inside the bone marrow with the Prussian blue staining. And the other half of the same disease is your basophilic stippling in the peripheral smear. So if we move to the next page, they have the basophilic stippling, which is under red blood cell inclusions. This is again seen in sideroblastic anemia, which can occur in lead poisoning, myelodysplastic syndromes, and thalassemias. This is primarily seen in the peripheral smear versus the ring sideroblast we just saw right now in the blue that was seen in bone marrow. This is actually aggregation of ribosomal precipitates. Alright, this is not iron in the red blood cell. For the longest time, many students have thought that basophilic stippling was basically iron that's stuck onto the red blood cell. It's not. Right? Pappenheimer bodies are a different thing. I wrote up here that a cell containing Pappenheimer bodies is a siderocyte. Reticulocytes often contain Pappenheimer bodies. They are mostly observed in post-splenectomy states and in diseases such as myelodysplastic syndrome, sideroblastic anemia, hemolytic anemia, and lead poisoning and sickle cell disease. And they're different things as well. So Pappenheimer bodies are recently being introduced. I don't think anyone ever actually heard about them or knew about them. I don't know if it's more of a new discovery or something that they're fixing, But generally, just remember that if you do get a question on basophilic stifling, and you will, then you want to make sure you remember that the blue dots here are not iron, they're ribosomal precipitates, just like we saw in the embryology video of Hem/Onc, right? So rRNA, ribosomal RNA in a sense. So make sure you remember that. The other stuff, schistocytes. So schistocytes, right, these are also called helmet cells. These are microangiopathic hemolytic anemias, including and seen in DIC, TTP, HUS, and HELP syndrome, right? Also noted for mechanical hemolysis. Same thing we're seeing here, right? So this one, these are all your helmet cells. They look like helmets. Now, whenever you see a helmet cell, though, and I told you to come back up here, right, with the bite cell stuff, whenever you get a question with helmet cells in them, do stop for a second and think of both things, the helmet cell as well as I said, the bite cell, because it could be this, right? Oftentimes the bites can be a lot bigger and the peripheral smear can get messed up and it can be very similar looking. Here, what we were looking at are actually helmet cells, right, which are not this thing, but this is because I told you, depending on the question, this same image could be given to you and it could actually mean to be a dacrocyte, a bite cell. Right? So you really got to figure out based off of the question stem. Don't entirely depend on the histological image that's given to you. Right? What we saw here are the schistocytes, and schistocytes are directly related to any of these things that cause fragmentation of your red blood cells. Right? So fragmentation, you want to think of like machine guns and stuff, and wearing a helmet, you're really just destroying your red blood cell. But at the same time, if you do get an image like this, do stop and consider the fact that it could be a bite cell, not just a helmet cell, and figure out if you can rule out bite cells, because G6PD is a very high yield topic. All right. So schistocytes versus dacrocytes right there. Sickle cell, we already know. They're cells that just look weird, so they start sickling into each other, and they all start sticking together because of dehydration, as well as deoxygenation, especially at higher altitudes. So people who live at higher altitudes and are sickle cell patients are often better off moving to a lower altitude. Last two things here, spherocytes and target cells. Spherocytes are just seen with hereditary spherocytosis. Very rare to see that, just like with elliptocytes. Elliptocytes are just seen in hereditary elliptocytosis, so they're both very rare to see. You can possibly see it in drug and infection-induced hemolytic anemia, but you would see other things more likely than this. And the last thing, target cell. Target, halt, set the hunter to his target is a perfect way to remember it because you will need to know target cells very well. Target cells are seen in hemoglobin C disease, asplenia, liver disease, and thalassemias. All of these guys have target cells. Right, so at least at that point you know that a target cell isn't specific. So just because you see a target cell doesn't mean that you know exactly what the diagnosis is. But if on your answer choices you only have one of these four guys, then you definitely know exactly what the answer choice is, right? So it's nice that the test is multiple choice because otherwise you'd be looking at 4 different diagnoses just based off of a target cell. Down here I have a question. A 34-year-old man comes to the physician for a follow-up exam. 1 month ago, he underwent splenectomy after being involved in a motor vehicle collision. He recovered uneventfully and was discharged, so everything's fine. Physical exam shows a well-healed surgical scar that extends from the xiphoid process to the umbilicus. Which of the following is the most likely to be found on a peripheral blood smear of this patient? So he had a really bad car accident, and he lost his spleen, right? He got a splenectomy. So you would find target cells. Target cells can be found on the peripheral smear of patients with asplenia, right? The A of halt. Thalassemia, liver disease, ABC disease, and possibly sickle cell. They don't put sickle cell here. I'm not 100% sure if you will see target cells in sickle cell disease. The only reason you would see target cells in sickle cell disease is because in sickle cell you have autosplenectomy, so it's the loss of the spleen that's causing the target cells, not the sickle cell disease itself. So make sure you understand that. Normally, macrophages in the spleen remove abnormal red blood cells from circulation. Because this patient no longer has a spleen, abnormal red blood cells cannot be removed, which causes target cells to remain in the blood. Other hematologic abnormalities found in patients who have undergone splenectomy include Haut-Jolly bodies, neutrophilia, decreased production of immunoglobulins, and reactive thrombocytosis. This here is an image of a peripheral blood smear again showing hypochromic red blood cells in which the ratio of the cell membrane to cell volume is increased. The cells are bell-shaped and display the classic target cell appearance. The electron microscope image shows a sketch of a target cell with the red line depicting the visual axis. So let me make it bigger. So right here we can see some target cells, right? 1, 2, 3, all the ones that are circled in red, those are target cells. Right? This is a perfect peripheral smear. You have a couple neutrophils. They have the normal number of lobules in them. And you don't see any other weird things. And then this electron cartoon imaging is showing you the weird shape that red blood cell has. Right? And the direction we're looking at it is this red line. So we're looking at it in that direction, and we can see the target type design that it has now. Last thing over here are your red blood cell inclusions, right? So the red blood cell inclusions, we already talked about the basophilic stippling, which is due to ribosomal remnants in sideroblastic anemia or thalassemias. Heinz bodies are related to the bite cells, right? Where you bite out the Dacrocytes, you bite out the blue Heinz body. Seen in G6PD deficiency, oxidative stress leads to hemoglobin denaturing and precipitating as Heinz bodies. That's what that is. Phagocytic removal of Heinz bodies creates bite cells. Alright, so in G6PD deficiency, losing the spleen would help you not lose this, and you won't have any bite cells. Pappenheimer bodies that they mentioned here, what are Pappenheimer bodies? So they're siderocytes containing basophilic granules of iron in sideroblastic anemia. Right, so remember that basophilic stippling is not the iron-containing granule, it is the Pappenheimer body. Right, distinct from basophilic stippling, which are formed from ribosomal precipitates, and Heinz bodies, which contain iron and denatured hemoglobin. Right, Heinz bodies, G6PD deficiency. That's the iron with the hemoglobin. Whereas here, this is just ribosomal RNA, and Pappenheimer bodies, these are actually just ribosomal precipitates, no iron whatsoever. So really important to know that. I feel like now that they've been talking about Pappenheimer bodies and they're really, sideroblastic anemia is already a pretty big deal. Now, on step 1, it'll definitely be there, and it's very likely that Pappenheimer body will either be the main choice of a question, or it'll be tossed into many answer choices so that you can just be more confused and stressed. So be prepared for that. Know the different guys. Now here it starts talking about anemias, alright, and this is the breakdown of all the various anemias that you have to deal with. You have microcytic, normocytic, and macrocytic. So pink, green, and the blue. In microcytic anemia, your MCV is under 80, whereas in macro is over 100. Normal is in between. The only microcytic anemias are your thalassemias, anemia of chronic disease, iron deficiency, and lead poisoning. Alright, so all of these are the ones where you have an MCV that's really little. Macrocytic anemia, the main guys are your folate deficiency, vitamin B12 deficiency. Those are your main ones. Then there's orotic aciduria, which we looked at when we were doing biochemistry because there was orotic acid involvement there too. And Fanconi anemia, which is just a defective DNA repair. These guys are going to cause megaloblastic macrocytic anemia. Right? Very different from the iron deficiency anemia, which is microcytic. Non-megaloblastic are these weird ones, but the real, well, they're not all weird. This one weird one, diamond black fan, and then liver disease and alcoholism, which pretty much go hand in hand. Right now, liver disease, alcoholism, and folate deficiency also go hand in hand. So depending on what the real issue is, usually the question is going to be about someone who's alcoholic, ended up getting liver disease, and now has folate deficiency, and you go with the megaloblastic anemia. Very rarely or ever do you really pick non-megaloblastic anemia as an answer choice. It doesn't happen much. So when do you have normocytic anemia? Well, normocytic anemia is just anemia of chronic disease and iron deficiency. Again, the same things we saw here, but in the early phases. Aplastic anemia, chronic kidney disease. This is the big deal right here. Non-hemolytic normocytic anemia is just going to be from chronic kidney disease, and you need to make sure you remember that. In chronic kidney disease, you just can't make any erythropoietin anymore, and you just stop making new red blood cells. But the red blood cells you have, they don't change in structure or any kind of shape or anything. In the hemolytic one, here you're killing red blood cells, but the red blood cells you already have are not going to be smaller or bigger. See, the reason these guys are different is because in microcytic, now you're making red blood cells that are smaller. Whereas in macrocytic, you're making red blood cells that are too big. And it's happening because of some kind of vitamin or some kind of other molecule is messing things up. In normocytic, no outside guy is messing things up. It's your own issue. Right? So chronic kidney disease, that's your own issue. Your kidney's not working. For the hemolytic stuff, either you have some kind of thing that's in your body and killing red blood cells intrinsically or extrinsically. Right? Intrinsically is within the red blood cell or the blood vessel. Extrinsically is outside the blood vessel because of antibodies or some kind of weird thing. And we'll dive into that as we keep going. So here we're getting a very clear difference between the guys. So we can see normal versus microcytic anemia. Right, so normal red blood cells are on the left. You have microcytic anemia on the right side. So you can see how really big the pale area is in microcytic anemia. Right, so this is one showing you microcytic anemia right here. Right, the white area gets bigger, really big. In macrocytic anemia, there is barely any white area. The red blood cell is so big, it's like a really big balloon. Okay, so that's the main difference there. Don't get that confused. A lot of people like thinking macrocytic means the white area got big. That's not what's happening. The white area is a sign of emptiness. In microcytic anemia, it's extremely empty. Super empty. There's nothing in there. The reason you have that white stuff in normal red blood cells in the first place is because they're empty. They don't have a nucleus. They don't have organelles. In microcytic anemia, it became even emptier. You're missing things. So it became mostly white, right? And macrocytic anemia, it's full. It's not that empty anymore. So now you have no white area at all. So the next page, the first thing they discuss are your microcytic hypochromic anemias, which is this red area, right? So MCV under 80, you have your tail guys. So let's take a look at that. In microcytic anemia, the red blood cells are smaller and have a lesser red color, right? More white. They also have more central pallor. Can be due to problems with making heme or problems with making globin. Either one of those things. Globin issues are your thalassemias, while heme issues are usually iron deficiency. Lead poisoning and sideroblastic anemia are the other causes. So the very first thing they go into is iron deficiency, which is really high yield and extremely common. Low iron due to chronic bleeding, either because of a GI loss, at which point you're at a risk of colorectal cancer, and we saw this when we did GIT, or because of excessive menstruation. Malnutrition, absorption disorders, any kind of GI surgery that prevents you from absorbing iron, or increased demand such as pregnancy. Now, DJ Ice in for business was the way to remember what gets absorbed where, and duodenum, jejunum, ileum, in for business, right? So iron is absorbed in the duodenum, whereas folate is absorbed in the jejunum, and B12 is absorbed in the ileum. So if you have a surgery or anything that really prevents things from being absorbed from the duodenum, you're not really going to absorb enough iron in your body. And ultimately, all of that leads to decreased heme synthesis because you need iron to make heme. Labs are going to show you low iron, high iron binding capacity because everything is empty, so you can definitely bind iron. Ferritin basically mirrors iron, so if you don't have iron, you don't have ferritin. There's going to be more erythrocyte protoporphyrin, which is one of the earlier steps before you finish making heme. After this step, you're supposed to take iron and make heme, but you can't. So you're making a lot of substrates. You're accumulating substrates in the step of making heme. And elevated RDW, microcytosis and hypochromasia. I used to have a thing here for... Okay, give me a second. So RDW, I used to have a note on it first. I just wanted to check it before I told you. The RDW is your red blood cell distribution width, and it's basically a measure of the range of variation between red blood cell volume. All right, that's what RDW is. I could have sworn I had that note here already. Let me put it back in. RDW equals red blood cell distribution width. Measures range of variation in RBC volume as compared to standard CBCs. Alright, so your red blood cells should not all look different, right? They should all generally be the same size and the same volume. If they're all starting to look very different from each other, at that point you have a higher RDW. And a higher RDW, red blood cell distribution width, is very much related to iron deficiency anemia. You don't see it anywhere else. It's always just a thing for iron deficiency. So elevated central pallor, as we talked about. Symptoms of iron deficiency anemia, and generally any anemia, are going to be fatigue, right? Then some of these are unique to here. So conjunctival pallor, pica, which is persistent craving and compulsive eating of non-food substances. So you're literally going to have this compulsion to eat something like a sponge, maybe, right? Eat soil, eat clay, something weird like that. And that's a psychological thing that often gets used to make tricky questions regarding iron deficiency anemia. And one special way that that gets tested is actually by talking about pregnancy. You'll have a question about a pregnant woman who has iron deficiency anemia, and she's presenting to the clinic because she's really tired, and then they'll tell you somewhere in the question that she's been having these cravings to eat soil, right, or something weird like that, something that is not actually human food. And that's when you're supposed to be like, all right, she most likely has iron deficiency anemia, and all she needs is iron, and then she'll be all right. The last thing, spoon nails, right? Koilonychia, like this. So spoon nails, there's a weird pressing in of the nail right here because of iron deficiency. When we were in GIT, we saw Plummer-Vinson syndrome, and I had the plumber digs a hole or something, right? So it may manifest as glossitis, chelosis, Plummer-Vinson syndrome, which is a triad of dig, dysphagia, iron deficiency anemia, glossitis, and squamous cell carcinoma, right? So esophageal webs. You can actually die from this. After initial treatment for IDA, patients will have immature red blood cells that you can check with IgM sustain, and they're going to be blue because of the rRNA in the reticulocytes, right? So this is how you kind of can check if your treatment is working. So anytime you get a patient who's under age 50 with melena and IDA, remember that melena is black tarry stool due to oxidized blood in the feces, indicating bleeding in the upper GI. And the most common cause of that is peptic ulcer disease. If the patient is over 50 and they have hematochezia, then you need to do a colonoscopy because colon cancer is most likely, especially if it's a male. In pregnancy, blood volume increases by 50% and their red blood cell mass increases by 33%, drastically increasing the iron demand. So those are your three main differentials that you definitely want to consider anytime you get a patient with iron deficiency anemia. The other half of the screen right now talks about alpha-thalassemia, which is a globin issue, right? This was a heme issue up here. Now we're looking at a globin issue. So alpha-thalassemia, you have alpha-globin gene deletions, decreased alpha-globin synthesis. And I remember way in the beginning of embryology, we saw that you make alpha-globin at a fixed rate forever. It never really stops. It never really went down, right? We saw it right here. After the liver started synthesizing blood, right, during the fetal stage, you started making alpha chains and you never stopped making alpha chains. But for some reason in alpha-thalassemia, something is wrong, and you probably never even started making it, or it got deleted later on, and you no longer have alpha-globin synthesis. You can have a cis deletion or a trans deletion. The cis one is Chinese, so you get deletions occurring on the same chromosome, and that's prevalent in Asian people. Trans deletion is a deletion that occurs on separate chromosomes, which is prevalent in African populations. The normal is just having all of this, right? All four of your alpha genes. So now you can see that there's different things happening as either one or all four genes are disappearing. If all four genes are disappearing, the baby just dies. There's no survival. Without any alpha chains whatsoever, the baby will die. If only one is lost, this is alpha-thalassemia minima, nothing happens, like literal minima. It's a silent carrier. If you have a trans or cis deletion where two genes have been lost, this is alpha-thalassemia minor, right? Mild microcytic hypochromic anemia. The cis deletion may worsen the outcome for the carrier's offspring, right? Because if this is the parent you are, right, and this is what you kind of transfer over to your next child, then the next child is going to get something like this or like this if you marry someone else who also has a cis deletion. Right, so you're going to be really lowering the chances of giving alpha genes to your offspring. But other than that, cis and trans deletion for the patient having the deletion is going to have the same issue, mild microcytic hypochromic anemia. Just got to make sure that if the patient has a cis deletion, that they not marry someone who also has a cis deletion, because then you can combine two cis deletions and get case 4, which is hydrocephalus. They're going to die. The baby's going to die. If you're missing something like this, where 3 of them are gone, this is hemoglobin H disease, right? And in hemoglobin H disease, since you can't make alpha globin chains at all for the most part, you end up having excessive beta globin forms of B4, like that. Right? So this is going to have moderate to severe microcytic hyperchromic anemia, but they don't die. However, they're really fatigued and they're hanging on to life. Right? Missing everything is Bart's disease, and that's just going to have globin and G4 chains in there. Right? Globin was from the beginning. Let me go back to it again. The gamma thing, right, from fetal hemoglobin, that's just going to stick around. All right, so that gamma stuff from the fetal stuff is going to stick around. Doesn't really do the job though. When they say excess is because that's all you're able to make, you never started making alpha. It doesn't stick around though, and that baby's just going to die. So that's really all there is for alpha-thalassemia. It's not that crazy. Most questions are generally going to be a genetics related question, talking about, you know, the deletion of genes and how it's going to get passed down and stuff like that. But make sure you remember the names, I guess. Hemoglobin H disease and hemoglobin Bart's disease. These are pretty low yield, but these are really the only major diseases that come out of alpha-thalassemia. Beta-thalassemia is more high yield than alpha is. In beta-thalassemia, you have a point mutation in the splice sites or the promoter sequences, or both, which leads to a decrease in beta globin synthesis, which obviously is what happens in beta-thalassemia. So that part you knew. But you got to remember the point mutation part, especially in splice or promoter sequences. It's not a mutation in the majority of the gene itself. It's actually somewhere in the splice site or the promoter sequence. But the coding of the beta globin is okay. Prevalent in Mediterranean populations. You can have beta-thalassemia minor, where the beta chain is just underproduced, so it's usually asymptomatic. And when you try to check all their hemoglobin, you're going to note that they have more hemoglobin A2, which you're not supposed to have that much of. Majority of it is just supposed to be hemoglobin A1. Hemoglobin A2 is supposed to be less than 3.5%. Beta-thalassemia major is where the beta chain is completely absent. You don't have the beta chain. That's really bad. So you get severe microcytic hypochromic anemia with target cells and increased anisopoikilocytosis, varying shape and sizes, right? And that's in image C. So if we go to image C, you can see right here, right? Some of these are really small, some of these are really big, and then you have target cells, obviously, right? So that's what they're talking about with anisopoikilocytosis. The cell just gets really messed up, requiring blood transfusions, which can obviously lead to secondary hemochromatosis. We saw that in GIT pathology. Marrow expansion can lead to a crew-cut skull on X-ray, and that's this thing. So basically, more of the skull is becoming bone marrow. So you have lesser skull and more bone marrow in here now, and that's your crew-cut expansion that you can get. That's directly related to beta-thalassemia. You don't really quite see that in alpha-thalassemia. Extramedullary hematopoiesis leads to hepatosplenomegaly. Basically, you're trying to make red blood cells everywhere you possibly can, but it's not really working too well. Chipmunk facies I skipped right here. So basically, all your skeletal muscles are going to try to replace the bone with more bone marrow, which is going to just mess up your bone everywhere for the most part. Beta-thalassemia patients have a microbiology relation. They have an increased risk of parvovirus B19-induced aplastic crisis. Right? Parvovirus can cause aplastic crisis. It's much more likely to cause it in beta-thalassemia patients. So what do you see in them? Well, they can't make any beta chains, so this is what they will make. They'll make a bunch of A2 delta 2, which is the hemoglobin A2 once again, and A2 gamma 2, which is just your fetal hemoglobin. The fetal hemoglobin is protective in the infant, and the disease becomes more symptomatic after 6 months when the fetal hemoglobin formation declines. The very last thing on this page is HBS/beta-thalassemia heterozygote, where you have a fusion between sickle cell and beta-thalassemia. So these patients have mild to moderate sickle cell disease depending on the amount of beta globin production. Okay, and then this is just a table from UWorld, pretty much summarizing the various different hemoglobins that you're supposed to know of. They have weird names, they have these shapes. You don't need to know the embryonic ones very well. They're not that significant. Do remember that the fetal one has gamma 2. Adult is mainly just supposed to be A1 with alpha 2, beta 2. But if you can't make any beta chains, then you end up getting alpha 2, delta 2. And you end up making more of the hemoglobin A2, which is very rare. It's just supposed to be about 3%. Alpha-thalassemia had hemoglobin H and then hemoglobin Bart's disease, and these two are like this, beta-4 or gamma-4, and that's it. Okay, so that stops right there. In the next video, I'll keep going into lead poisoning and sideroblastic anemia, and we'll... Oh, actually, wait, this is still macrocytic. I'll do this too, and I'll stop here, and then we'll continue macrocytic. So the other two microcytic anemias are lead poisoning and sideroblastic anemia, of which both of them are actually really, really high yield, but sideroblastic anemia has some new shit in it now. So lead poisoning, basically what happens is lead stops furochelatase and ALA dehydratase from working. And later on, when we get to the portion of actually making heme, we'll see those enzymes and we'll see what happens when they stop working. But overall, the main issue is if they're not working, you won't make heme. So you have low heme synthesis and more red blood cell protoporphyrin, which is one of the substrates before actually finishing heme synthesis. It also inhibits rRNA degradation. Right? So you end up finding more rRNA, and that causes basophilic stippling. Right? This is new. This wasn't actually this way before. Before, everyone used to think that the basophilic stippling was just iron on the red blood cell, and it's not that. All right. So rRNA degradation is actually slowed down because of lead poisoning. So you end up having more rRNA on your red blood cell, and you see that as basophilic stippling. But the Pappenheimer bodies are the iron bodies that you're going to see, but there's no hemoglobin in it. It's just iron. Symptoms of lead poisoning are lead lines on gingivae like this. So lead lines on the gingiva of your teeth, they're called Burton lines. And on the metaphyses of long bones, as in image D. So if they give you an image like this, you see weird stuff, and it looks like it's an anemia question, think of lead poisoning. It also causes encephalopathy and erythrocyte basophilic stippling, as we just saw. Encephalopathy because it's going to the brain, and because you need your red blood cell for your brain. Abdominal colic and sideroblastic anemia, so they can definitely present with a bunch of abdominal pain, and then wrist and foot drop. All right. So that's more of a neurological manifestation. Dimercaprol and EDTA are the first line of treatment, and you have to make sure you give either one of those two as an answer. Succimer is just used for chelation. It's not the ultimate treatment. It's just used for chelation to help kids who have eaten lead from God knows where. Exposure risk is increased in old houses with chipped paint, and this is something that can be given to you in a question. I think I have the question somewhere here later on, but basically there was a question on UWorld where there's a guy and he's supposed to bring his kid into the doctors to get like a regular appointment in, but he's unable to do so because they're very poor and they live really far away from the main city. And then it tells you somewhere in the question that their house was built in like 1970 or something. And they tell you that the child is regressing. Like he used to be able to talk, now he's not talking so much. He's got lead poisoning, right? So you really have to be able to figure that out based off of what the parents are telling you, because the parents aren't going to come and just tell you, oh yeah, we have chipped paint with lead in it, right? You have to deduce that based off of whatever they did tell you. Last thing here is sideroblastic anemia. This is an X-linked defect in ALA synthase, or it can be acquired due to myelodysplastic syndromes, or it could be reversible due to alcohol, but also vitamin B6 deficiency, which is a really weird deficiency. In nutrition, when we were looking at vitamin B6 deficiency, we really couldn't figure out a very easy way to see that it's B6 deficiency. Mainly, you would get B6 just because all the other vitamin deficiencies don't fit. All right. And isoniazid and linezolid. Remember linezolid and tigecycline, the two medications you use in microbiology for really, really strong bacteria that don't really listen to anything, like Enterococcus. And isoniazid from the RIPE therapy. These guys can also cause sideroblastic anemia. So what do you see in labs of sideroblastic anemia? Well, these guys have high iron. They have normal iron binding capacity. And they have high ferritin, which always mimics iron. You'll find ring sideroblasts, which are iron-laden, Prussian blue-stained mitochondria in the bone marrow, right? And then the peripheral blood smear will show you basophilic stippling of red blood cells, again, which is just rRNA. Treatment here is by giving pyridoxine, which is B6. B6 is actually a cofactor for ALA synthase, and we're going to see that later on when we get to the part where we look at all the enzymes that are working together to make heme. Okay. Down here is a couple questions, so let's make sure we understand that, and then we'll look at this table later on. So this question from UWorld, this one says, a 40-year-old woman comes to the office with a 3-month history of progressive limitation of physical activity due to fatigue. She says, I could barely walk from my car to your office. Past medical history is significant for a positive tuberculin skin test 7 months ago with a normal chest radiograph. She has been compliant with prescribed treatment despite its bitter taste. Physical exam shows a tired-appearing woman with conjunctival pallor. CBC shows a low hemoglobin, low hematocrit, and microcytic 72 MCV. Bone marrow aspirate revealed the image given below under Prussian blue stain. Decreased activity of which enzyme most likely explains her anemia? And you just go and pick allosynthetase. See, vitamin B6 was really significant when it came to TB, right? Because isoniazid actually makes you lose vitamin B6. You need to give B6 with isoniazid together. They compete with each other. So in this patient, her allosynthetase is not working, and that's why she has microcytic anemia. Her latent TB with lab values in a bone marrow aspirate consistent with sideroblastic anemia are all going to be due to isoniazid use. That's probably the medication she's taking with the bitter taste. Sideroblastic anemia is diagnosed by bone marrow exam with Prussian blue stain. Causes include many things that we've already looked at. Isoniazid directly inhibits the enzyme pyridoxine phosphokinase, which normally converts pyridoxine to its active form, pyridoxal 5'-phosphate, a cofactor for allosynthetase. Inhibition of the enzyme produces the microcytic hypochromic anemia. Iron is transported to developing erythrocytes that cannot form heme, and iron granules then accumulate circumferentially around the nucleus, forming ringed sideroblasts in the bone marrow, not in red blood cells. The pyridoxine deficiency can also lead to dermatitis, stomatitis, neuropathy, and confusion, so give B6 with isoniazid. Right? And this over here is your ringed sideroblast that we're looking at, apparently. I think that's about it for that. In the next video, I'm going to go on from here. We're going to look at this comparison of iron, understand the iron panel and what's special about it, really understand hepcidin. We talked about the iron panel in hepcidin and a couple other guys in GIT a little bit. We'll talk more about it over here, finalize that stuff, revisit GIT a little bit, and then move on into macrocytic anemias.